Starting with our program, our next lecture would be delivered by Professor Padma on Artificial Intelligence in Neurosciences.
I hope all those people who have left with the chief guest will return. There's still an oration after this, so please come back. Shall I start off, sir? Yeah, I think we should start. No formalities. So, good afternoon, ladies and gentlemen. First thing, it's a great honor to be here. I love to be amongst neurosurgeons. So, there we are. That's a disclosure. And so, all my teachers and my colleagues and friends, colleagues, again, welcome again back after the inauguration. So my topic today is artificial intelligence in neurosciences is what Deepak asked me. So since I'm biased towards neurology, I made it neurology, but what I guess it's applicable all over across the spectrum of neurosciences, so it is. So we debate whether it is our friend or it is a fiendish friend as at that. Now there is a famous quote by Hippocrates, it says life is short and art is long. Opportunity is fleeting, experience treacherous, and judgment difficult. And I don't think there's any other better way of summarizing the dilemmas that we clinicians face when we have to manage patients, isn't it? So we would sometimes need a little bit of help. So let's see if machines can help us out at that. And then the machines do help us, so then we have the artificial intelligence, which we had designed that they would help us out in these kind of dilemmas, and then they seem to have evolved. And so then this artificial intelligence, the term which has come up because they seem to think and behave like humans. So traditionally what was thought to be a living brain capabilities, and especially to do with humans, of problem solving, is something which the machine started to do. So that's the term, the artificial intelligence. Now the talk is going to be more layperson. I'm not going to get into the deep neural networks that the deep learning of AI has, but as I understand, the AI essentially is a machines which seem to be capable of behaving like humans do, essentially in adaptation and learning the logic and breaking the rules, and then of course beyond and thinking out of the box, which machines never did. Machines simply did what we wanted them to do. And then it evolved into deep learning, and then there is this term called artificial neural networks, and it really drives home closer to what a brain would be. They're actually talking about neural networks. And so this is a string of terms that I don't understand. They're not really tongue twisters, but they're definitely brain teasers, and I'm not going to talk about that. But essentially, what I understand is that there is a supervised learning and there is an unsupervised learning. So supervised learning is something that all of us are going through, we've been through. So there is an algorithm, there is a curriculum that we keep devising, and you stick to that curriculum. There is a learning method and there is a question bank, and then you're exposed to those exams. You pass the exams, you get your degree, and then you learn your skills. That's supervised learning. And unsupervised learning is that you keep thinking out of the box every now and then. And after you learn the skills, then you develop your own skills. You spew out algorithms which were not built into your original curriculum. Now that's unsupervised learning, and the machine seems to have now evolved into that. There is a rule-based expert system, and that is what we all do. There is a didactic lectures, and there is a lot of data, and there are a lot of buzzwords which keep emerging in the universe. So we have the buzzword of nano, then we have this app world, and then you have this, this app-based techniques, and then the big data analysis, right? So when you have this data which is fed into like our Google Maps or whatever, there is a pre-fed data. So then it can also become real world experience, and it will help you in navigation, which most of your cars have as they've evolved. And then you have the tools which have gone beyond this. And then even in the real world, even if it is not fed into a system, the self-driven cars probably are using some part of this. In a real world scenario, they do not know, they are unpredictable. There's a sudden dog which is darting across the road. It will build in a system how to avoid that, or it will preempt and tell you the dog is there and is going to dart across the road. Now that is where it is getting evolved. Taking, there are few of those adaptations which have evidence so far, and that's what I will be dealing with. In stroke, there's a whole lot. The entire stroke trajectory, when you're starting with prevention into the community, into an outreach area, into where the neurologist is not there, and you're using the telestroke method, starting from then onwards, down to triaging, picking it up, and then the emergency, and the entire stroke algorithm of care, of acute management, to a stroke unit care, stroke prevention and a discharge plan, and then a rehab. The entire trajectory now AI has got into, and it has definitely evolved in systems based on some evidence that it has proven to be better. The reason I put out stroke as one of the examples is because as I speak to you now, the stroke statistics are pretty staggering. They're humongous. Every 20 seconds there is a stroke, every 2 minutes there is stroke death, and these are Indian Council of Medical Research stats, these are not mine. And it is true that in the developing world, where India is a prototype, stroke is definitely one big killer. And this is actually topping the charts in the Northeast states, and even the rest of the country, it's there in the top 5. So there are two important tenets, and my neurosurgery colleagues, so part of my stroke team, know that the two basic tenets is time, and it is those, I think, humongous advances in neuroimaging which has actually proven to be why we had this tectonic shift in how you approach a management, a patient with acute stroke. So we know whether it is CT or MR based, we know if it is a stroke, what type of stroke, if it is an artery which is blocked, what is the size of that artery, now can I unblock it, what is the reperfusion strategy I need to use to unblock that, what will happen if I unblock it, will I have a bleed in the brain, what is the stroke outcome, what is the chance of a stroke recurrence. So the entire, again as I say, this tapestry of what would happen to this stroke patient, I would know in 6 minutes flat, whether I'm using CT or an MR based technique, that I know that. Now we build into it the AI systems which will help us out. So do I need to, how to identify mismatch? The mismatch is not sine qua non, but then it is roughly the area which will actually predict which is a dying brain, which is not a dead. So that, as I say, it is an ischemic penumbra, is picked up, whether it is CT or MR based, but then now you have a commercially available software package called eAspects. And it is now known that it is non-inferior to human experts. And we know that there's a lot of subject variability. Even when I have to calculate the aspect score on a plain CT, there is a difference, even between the radiologists and the clinicians, or the neurologists or neurosurgeons. So that aspect, that variability, the subjectivity is sort of diminished when you're looking into big data and put it into an AI system. Identifying the large vessel occlusions, in the algorithm, if there is an LVO that I pick up, I know my strategy is different. I know whether if I have a hub and spoke model, maybe I can have the smooth transit of a patient to a care delivery where you can take out this. You can do a mechanical thrombectomy. That's possible. Now, how do you identify the LVO? Even if I have just had plain CT scan. And it is now seen that using CNN or the convolutional neural networks, that is possible, and with a 94% specificity. Not bad at all. And those are those things which are there right now with us in some centers, but they're very, very expensive. There is an IELTS challenge, which is a global phenomena, wherein this is thrown open as a challenge to all these transdisciplinary networks, which are biomedical engineers. There are even string mathematicians who are involved in this, who develop these kind of techniques, as well as the gadgets based on those AI systems. Even this hemorrhagic transformation, when you do any kind of an intervention or even otherwise, spontaneously, and it's been said that when you use this AI model, they're comparable to the clinical scores which have been developed. With a SIDAN score, the HAT score, there are a lot of score systems clinically developed, which includes biomarkers, including imaging. But when you put in AI, they've said that they do, in fact, comparable. So we can better. The moment it is comparable, it then starts to get better. Predicting long-term outcome, again, it's said that these neural networks can predict this improvement in an NIHS score. And when they put in right now they want this NIHS score system into the AI to better it. Maybe sometime later they won't even need that. And they've seen these accuracies actually topped more than 70% compared to all the scores that we already have, NIHS, yet Thrive, SPAN, whatever. Current. So sometimes I feel that maybe using this, now you can start predicting whether it is a hemorrhage or it is, a ischemic stroke using biomarkers without imaging. Maybe we'll get that, and that will be great, especially for forces in your outreach in, somewhere in Siachen. You won't never have a CT scan. But if you have a biomarker like a TROP eye, using AI, maybe you'll be able to at least even, diagnose that this is a stroke. So there are a lot of applications, and then the neurological functions, not just neurological functions, any critical care functions, which is, real time and it is ongoing. You can put in all this data in, whether it is blood pressure or a pulse rate or whatever, and this, lot of critical care and anesthetists are already using it. It can detect atrial fibrillation and stroke recovery, and I'll come to this daily rehab a little later. So technology and AI in stroke care, stroke prediction, triage, optimization, imaging, outcome prediction, everything. And the way it has evolved is like every tiny image, it is fragmented into pixels, and then those pixels are used to get this data in terms of definitive ordinals, and I believe they use, and I'm not an engineer, I don't understand these terms, but this is what is said that and anyway, engineers have a sharper brain, I guess, and we are more of mugshots, I think. At least neurologists are, not neurosurgeons. So the AI processing in stroke care and formulation of a diagnosis, choosing appropriate therapy, predicting outcomes, and everything which we have already talked about. So this is the way the automated aspects happen, and we have a rapid AI which is already in use. A lot of my stroke interventionalists and stroke neurologists use this. We don't have a rapid AI in AIMS, and I don't think any government system has this. This is horrendously expensive. So it's okay. So when you have this, then you're building in the cost of doing this into the patient costing. And that's one important thing, especially when you're talking about in subcontinent and all the developing world where you don't have a global insurance system and 70% of healthcare is still being done in the private sector. Nothing wrong with that, but then when you have a cost-benefit analysis, this is not figuring very well there. So you have a QRI which is also being developed, which is an India-based imaging automation system. It's a startup, and again the other buzzword I know now is all startups. So this startup is anyway seem to have arrived as well. They have some evidence which they have published. So this would provide you solutions similar to what Rapid AI does. Now Rapid AI essentially is being used in systems wherein they put in that, it will give you that solution of do I go in or do I don't. I mean, is it going to be a futile recanalization of spending some 5 lakhs and doing a vascular thrombectomy, or should I do it so that the outcome is actually going to be clinically useful for the patient? That's what the Rapid AI does. And these stroke solutions are there, and again, you can use both CT and MR based. The world is actually divided between believers who believe in CT versus MR. I'm not getting into that at all. We can use it according to a clinical perspective. There's actually can never be one glove fit all approach. And you can use it in even an ultrasound, and these networks have been used for actually looking at a plaque risk score, characterization of a plaque. Is it going to be stable? It's unstable. Is it likely to break and cause problems? These things can also be done automatically. Stroke risk assessment, as I said, when you're using clinical scores, this is bettering it. And a risk assessment for a CHATS-VAS, which we use for atrial fibrillation, this seems to be a better option than just doing those 6 parameters that we use for CHATS-VAS. And of course for outcome prediction, which is very important. And I guess for any intervention, and more so for neurosurgeons, I think the outcome prediction would be of great value when you have to build in that. So there's a whole lot of future which seems to be extremely bright. And for epilepsy, Well, again, there's a huge lot there, and Dr. Sharat Chandra will agree with me in this, that AI has really come in a big way, again, into the entire trajectory of epilepsy as a whole and all its syndromes, and as well as starting from very benign things to extremely intractable clinical scenarios, and also specifically for SUDEP, which is sudden death. And it helps, and because that is one real bugbear. It's not predictable. We do have biomarkers where you can say that, oh, maybe this person does have that, but then trying to do it and therefore avoiding it would be great. And picking up those, the non-epileptic seizures, etc., and also, again, it tries to get down the subjective variability and inter-observer variability, especially in interpretation of some stuff like electrophysiology. Similar things for neuromuscular. So when you look at an EMG or an electrophysiological parameters, there are 2-3 pages of lot of numbers. And again, when you look at neurology interpretation of a simple thing like nerve conductions in EMG, it's variable. And EEG especially, people miss little transients, and you really require a lot of, what Dr. Manjari would interpret will be very different from someone who's not dealing with epilepsy. You will miss a whole lot of stuff. So that kind of thing, when you have an app which may help even in outreach area, at a district level, at a physician level, this would be helpful. So this is a thing in neuromuscular, neurodegenerative. I think it has evolved into systems where it can help in coping up with a disease much more than actually trying to find a solution to the disease in terms of cure. I don't think we've done that, but especially in motor neuron disease and other aspects, how to cope up with this disease. And also when they start off early, when every tremor is not, give me 2 minutes more. So if every tremor is not Parkinson's, now every time there is somebody slow, it's not getting into this. Every time somebody forgets, it's not Alzheimer's. So there are algorithms which probably help in when you have an AI. And I would think that this is helpful in essentially areas where there is no big, the super specialty courses, and with a 1.42 billion population in India, and we probably around 2,500 or 3,000 neurologists and probably a little over neurosurgeons, you can never match that. I guess we are likely to add another Australia. Every year we add an Australia to us, so it's tough. It's not going to meet that kind of a thing. So emergencies, yes, and the systems, as I said. Now, there are a lot of gadgets which are already out there. You have Apple Watch, you have iPads, and you have all these things which are already there. And a lot of people are using it, and I do see these extremely nice watches that people wear and they use it. Somebody's telling me to go, so I'll come down to barriers. So there are barriers out here which probably are concerns. There is something called a human touch. We still don't have an AI touch yet. And I know people just come to you. Motor neuron disease patients sometimes come and visit, and they just say, we want to speak to you. And if you actually put your hand on someone's arm, I'm telling you that comfort, that human touch is something else. And therein comes an empathy. I don't know, that's the reason I said as far as the machines start developing souls and start empathizing and have that, those kind of feelings, I really do not know. Maybe that's where the AI is going. And you have all this fictional stuff and also these movies which have come out, but I'm not sure. But then there are practical issues too about licensing, about cost factors, about medical legal systems. Something goes wrong, then who is to be blamed? You blame a machine. So there are issues which need to be a lot more streamlined and a lot of stuff out there. And the dark side is always there. They're black box models, and that's what we're most fearful about. And there are great movies. I don't know, some of the young ones may know about the recent movies which have been dealt with this AI systems, how the machines control. And the age-old, that Schwarzenegger movies used to be there. They are pretty old now, but then they have evolved. And so whenever I look at fiction or the movies, they actually look at the future and see. They have great minds. So we still don't know these algorithms, how they spew out, which we don't understand. So, but then it's not the strongest of species, but it's the most intelligent ones are not the ones which survive, it's the ones who are responsive to change. We need to adapt, we have to evolve. One last line before I'm completely, thrown out of this stage is that, there's one thing which I had read in one of the books recently. It is said that it is much easier to get artificial intelligence or develop artificial intelligence than to counter the natural human stupidity. I think that is pretty profound. So thank you.
They will ask questions. Sir, there are brilliant people. They will ask you questions to get your. और है हमारा लड़के लोग क्वेश्चन पूछो भैया मैडम से. I was only asking how to predict China will attack India or Pakistan will attack India.
So, but that's not neurology or neurosurgery. But
50 years history from independence and see the probability China first or Pakistan. It's possible.
It's possible, but there is a fiction by Ashwin Sanghi. He's one of the, I don't know how many of you have read any of his books. In that, he actually got his, did you read that book, sir? I don't know. Okay, so he actually talked about AI into this China-India thing at the Galvan Award, and it's very interesting what he talked about is a development. Actually, he said that there are two things he said, that you have the Sun Tzu's philosophy, who's a Chinese in the art of war, that you win the war, the best way is to subdue the enemy without actually fighting. And he also said that, you appear strong when you're weak and you appear weak when you're strong. So those are strategies. I think the army guys know this much better than me.
If there is a war,
yeah.
how many days they will take to take over India?
No, sir, let's not get into that. Of course not. India will always win. But the thing is that what he was saying is that they're trying to...
Prediction AI says.
AI says that we have to develop men into machines and the machines to think like men. Dark side.
My question was most
Thank you, Dr. Padma, for the delightful lecture. I'd like to invite Dr. Jogi to deliver his lecture on India and head injury, a view from afar.
Namaste, friends. Thank you for allowing me to speak. Thank you for all the hard work that all of you do. And thank you for making this motherland a very proud thing to look at from outside. I stand before you representing many of my friends. And Wilco is right in front of me, and I talk about Shlomi and Concesio and Rick Boop and all my friends. When we look at India today, we see the bright future, the dynamism, the energy, and the activity. A land that could not make a pinch of salt or a safety pin in one decade, look what you all have achieved. Look at your airports, your hotels, your hospitals. Everything has improved. We're not there yet. The cooking is still going on, so you cannot complain that, hey, we don't have a meal because the cooking is still happening. But the road is built. And since the road is built, you're walking and you're taking people with you. And that kind of progress is what I'm seeing since I left India in 1969, before many of you were born. I grew up in America since age 11. I've been back to the motherland at least 50 or 60 times since 79. And I'm witnessing each time I come the beauty. Otherwise, why would Wilco come for 20 hours? Why would I come to India for 30 hours? Why did Andrew Mas come for 24 hours? We do this because we know there's something good that we can also take back. For that, we thank you. This is a picture of my notes. It basically says, what did you do today to improve India's dismal head injury statistics? I wrote this to myself. Some things you can't, you don't sleep. Like Abdul Kalam sir told us, some of you know that we're very close to him, and he'd been to his house many times, and he's been to our house. And Abdul Kalam always would say, dreams are not what you get when you're asleep. Dreams are what keep you awake. And this is things that I look at. What can I do? Where do I find the beauty? Where's neurotrauma in India happening? I'm going to share with you some thoughts. You all know all this. There's no science today. It's the basic, looking at yourself as a neurosurgeon right there, friends, neurologist, neuroscientist, Dr. Padma. You're right there. You're working your buns off in the heat. You don't see what you're doing. That's what you are. You're doing all this today. But from far, you see a beautiful garden. When I go to France, when I travel the world, you see beautiful jardin from the view from the top, and that's what I'm seeing. And I want you to take a moment to say, wait a minute, we are doing something well together here. It has started. The road is built. And by the way, consultants like others can help you, but the work is done by the home team, You are making the change in a positive way of these 4 aspects. All of you well know, prevention, prevention, prevention. I'm talking about helmets. We had a rally in Visakhapatnam. We're working on pillion rider programs. I'll show you more. Friends, we can do all this work, and I've learned so much about what's happening in pre-hospital care from going to Hyderabad and spending time with GVK MRI. Dr. Abdul Kalam and his team put us in touch with those people, and Dr. Krishnan Raju and Ramana Rao and all them people, and they've been helping us. Sumit Sinha and all of you have written all this stuff about how to manage patients in-house. You're doing much, much, much better than you were 20 years ago, and we have come from the West to learn. A little caveat. I was visiting professor at Nizam's in Hyderabad. In the operating room, I was watching a surgery when the postgraduate brings in a CT with a big contusion and some moderate-sized ventricles. Immediately, the professor says, okay, use up the next room and do a decompressive craniectomy. I mean, just decompress. I was shocked, because in America, we'd put in an ICP monitor, we'd ventilate, do this and this and this. Maybe 4 days later, we'll consider it. Friends, I stand before you saying now that type of practice is now being done globally, which I saw earlier here. It wasn't publicized, it wasn't written, but you were doing it. You just didn't take the time to put it in some literature, but you knew that was the right thing to do early on. That's the kind of work I want the young people to help us learn more from. Yes, you mentioned earlier, it's a unified effort. You have pockets of expertise, pockets of greatness. I'm standing before you in AIMS, one of the premier institutions in the world. I visited many times with Dr. Mahapatra, with Dr. Tandon, with Dr. Sharma, of course with Dr. Kale. I've been there many times. It is interesting, the great luminaries, who were here before, the week before, the week after. So you stand among the world's best. Some of the young people may or may not know this little formula, IIT equals MIT plus Harvard. Watch 60 Minutes, there's a piece on it. It's true. In America, we do notice the greatness of AIMS, IITs, and et cetera. And once again, as part of all this, you will do the prevention. I think Deepak's organized another rally, which I've seen so many of them in India, and they're working. We're doing it small steps, but we're doing it, and it's going to coalesce. Guidelines. Matthew Joseph, I don't know where he's sitting, but Matthew, under his guidance as the president of the NTSI, we released the guidelines at the meeting in Visakhapatnam. Took a long time to make it, many, many revisions. Hats off to Sumit Sinha, hats off to Dawal, Dr. V.D. Sinha, Dr. Gururaj, so many people wrote this together. One of the slides I showed you, like there are 40 of us in Delhi, and a lot of work. Writing the guidelines is not the hard part. Now we have to test it, use it, and show it works, and then it's a living document, so we'll make changes as we go. Just a little bit of data from the Visakhapatnam Helmet Project. Anil and Dr. Vijay Shekhar and the team are sitting here. Friends, to teach people how to use helmets and to make it happen, to prevent a head injury. It's much better than how many operations I can ever do. In this data, you can see it went from 35.53% in July 19, sustainable 94.11%. After training, education, police, everything was done. And that stayed through post-COVID. That's the beauty. And now we're working on pillion rider helmet usage. Delhi, I think, is doing a good job. This is progress. Be proud of these notes, these things that are happening. You may not know this. The pre-hospital care. You know what? It is a problem. It is a problem because people like me and visitors, and I bring many people from abroad who come. They say, what if I get hurt in an accident? What if I have a chest pain? Can I get to the hospital in time? Will I be stuck in a traffic jam? Will I get the proper care that I'm used to, that I'm expecting? And the answer is, I think you're getting there. You're getting there. The GVK MRI model is 108 is a good one. There are others, and they are working, and they're improving. And the answer to all this, education, education, and more education. Dr. V.D. Sinha gave me this slide when I think he was the president of NTSI. Yes, India still lives in the 2 centuries. You still have bullock carts. I was in Visakhapatnam, I think it was Visakhapatnam, as we're going into the casualty ward for something, a patient with, I think, a head injury was brought on a motorcycle, vested or sandwiched between 2 people, the person riding the third person and the head injury person in the middle. That's how they brought that person in. You know what, it's happening today, but maybe it'll get less and less. This is a study on the pre-hospital factors from Visakhapatnam, and yes, today still more patients come by private than they do by ambulances, etc. These are data from the GVK MRI people, and quite frankly, they're not that bad, friends. From receiving a call to hospital, 38 minutes, arriving to the scene, 13 minutes. In the rural area, the middle section, it's about 30 minutes arriving to the scene, 20 minutes from receiving the call to the scene. Once they get there, obviously they're doing some treatment. In the tribal area, which a great portion of India is, it is about twice as long. But they're working on it. At least people are looking at this, looking at the data, and developing things for education. Publications are increasing thanks to Neurology India, the Journal of Indian Journal of Neurotrauma, and others. You have now shown the world what you're capable of doing. We need to see more. When I came to India the first, there were 800 to 1,000 neurosurgeons. Now you have 3,500, maybe 4,000. Use some of that extra manpower, woman power to study, learn, to see what you can do, improve. Still a weakness in India. We do not have enough neurorehabilitation, but I'm proud to say a recent study that was just published, again by Dr. Vijay Shekhar and the team, shows that there is some improved outcome. People are paying attention in the homeland, for that which I'm very, very grateful. A slide from this morning's talk from Vivek Tandon. Very, very good news. I asked this question so many times, and yes, not only do you have a Good Samaritan law, there's a little benefit to you in case you do stop and help. The police are not harassing you for 2 years, etc. Numerous publications, too many to count, but the numbers you have will not be matched by the world. And I think Dr. Welker just said that earlier. Anybody in the world will tell you the numbers you can generate in 6 months cannot be matched, which is why we from the West are looking to you to answer questions that need to be answered forever. And I'm proud to see your journals are doing good work, and I'm proud to see publications in there are influencing what other people are saying. This is a very nice paper, beautifully mentioned. Dr. Mahapatra mentioned earlier, Deepak Gupta and Monica Vavilala, Seattle and Ames compared 200 patients, exactly the same, outcomes exactly same. Only problem is, in India, after they go home, they still have more deterioration and dying from other complications, where in the West we have rehabilitation and maintenance. We can improve with that. If I could ask, is Karthik, Anil, are you guys here? Can I borrow you two for a minute? Anil and Karthik, are you here? Here, come on, both of you, please. Just for a second, come here. Friends, these are 2 postgraduates I met. Rather than hearing from me from afar, you should hear from the people who are on the floor, who are with you working, and the future. Take a word, say what you want to do.
Good afternoon, respected members and the dignitaries. I'm a second year postgraduate MCH resident from Rangaraya Medical College, Kakinada. And as my elder faculty told, we are still suffering a gap between the management and the input we are having to our hospital. So still we are having that only one theater and waiting for our turn to come. And also we are forced to admit all the polytrauma patients, even at least in our center. And the next thing is, this positive outcome is coming, we are improving, and we are of the view that all the teaching hospitals should have a separate trauma center for dealing all polytrauma along with the neurotrauma. Thank you, sir.
Good afternoon, everybody. This is Dr. Anil, second year neurosurgery resident from RMC Kakinada. I would like to just mention few points that in recent times we have getting a lot of RTA cases. We are increasing year by year. So we are somewhere we are lacking in resources or in prevention. So it would be better if we share the message via mass communication or TVs and all. Then we can able to reach out to people, and we can prevent RTS and also. And actually we have we spoke to the local theaters as well to project any sort of awareness in the interval period, I mean during the interval time. So they have some issues and all, so
Excellent.
they have some issues, so we actually show people to awareness program regarding wearing helmets and seat belts and all.
Thank you.
Thank you, sir.
Thank you so much. Thank you, guys. I just asked them this morning if they would talk instead of me. You don't need to hear from me from far away. You need to hear from the future. That's who's going to be taking care of you and me if we get hurt. I'd rather they get the credit and they do it all. The glass can be looked at as half full or half empty. I'm seeing it's more than full. I'm seeing it's growing. I'm seeing better. We can use big data. Andrew Moss has talked about this, and I think we can do this. Professors Tandon and Banerjee, we talked to them this morning. They gave me their blessings, and their power is what sustains me to do this. We now have various pockets of expertise. These need to coalesce. You need to do multi-center trials. You need to do big numbers. You can do this. What happens in AIMS stays in AIMS. It's not the same as NIMHANS. It's not the same as CMC. Why should it be that? Why should CMC and Dwarkanath, why should your place be different than this? You should all see it the same. Why don't you all write the same protocols and follow the same? We do it in the West. Please, that's your next step. And the numbers you'll get will be phenomenal. Nobody can beat your work. We can learn from you. All the questions that are out there, you are all capable of answering and teaching the rest of the world. Jai Hind.
Any question? Three questions. Juniors, always say seniors are asking question juniors. Junior, training. They know everything.
I'm comfortable. This was not a scientific presentation. It's a feel-good talk. They can ask me questions later, but the most important is, thank you. You're doing good work, and from the West, we are very appreciative of what's happening here. Namaste.
Our next speaker would be Dr. Samuel Kaba from Africa. He'll be talking about the neurotrauma care in Africa.
And I see you guys ringing the bell. What was this stuff?
तो पहले इसका है सैमुअल का, इनका तो नहीं है। इसके बाद डॉक्टर
So you see neurotrauma care. Welcome. Neurotrauma care.
छोटा रहता है इसमें, उसको फिक्स कैसे करो? फिक्स नहीं होता। हाँ, इसका कोर्स होगा। और सर वो सेंट्रल और सेंट वाले में सेंट से काउंट हो जाता है या
Good afternoon, everybody. Chairperson, and I feel honored to be here for the first time in India, and second, to be within highly esteemed colleagues. It keeps everybody nervous, is it? Including me. So I'll take some few minutes to talk about neurotrauma care in Africa, or in Ghana first, and then Africa as a whole. My name is Samuel Kabar. You can find it over there. I'm the Director of Clinical Service of the Ghana Health Service, and I'm a consultant neurosurgeon and a public health physician. So these issues, I kind of understand them from two different points. One as a clinician who works as a neurosurgeon, and one as a public health physician. So two things. Now, I can't talk about this without talking of my country. We just 32 million people from West Africa. That is like having Delhi, so we are just small people. I had a video here, but I'll skip because of time. But the first thing to talk about neurotrauma from general point of view is to look at it from pre-hospital care first, and that is where the Star of Life was born, where we first need to start looking at early detection. Do I have the pointer? Anyway, so you have to first talk about early detection, early reporting, early response. So good ambulance system to transport the patient to the hospital, and when he gets to the hospital, what to do. So it's not just about we neurosurgeons waiting to operate, but how do we prevent all this? Now, if we look at African situation, for the past many years, we always talk about public health issues, and WHO published this in 2015, where you see that by 2030, most of the diseases that will be a problem for us are going to be road traffic accident, traumas, whilst HIV, TB, and malaria are going to reduce drastically. This was also seen when the Lancet published its document in 2015. You can see below that the same thing would happen. Now, for many years, whenever there are interventions in Africa, it's all about public health issues, maternal issues, vaccines, TB, HIV, malaria. And we've gone through MDGs to SDGs. And in all that, there's only one goal in the SDGs that talk about emergency, which is target 3.6, and says that by 2020, half the number of global deaths and injuries from road traffic accidents. Now, we are in 2023. What has happened? We've not achieved much. And as long as much is not involved, funds are not put into this, we can't achieve much. Again, Lancet published this, and you can see all the brown areas means that these places lack surgeries. So then, okay, very good, thanks. So what we see here is very simple. These challenges are more in Africa simply because we have constant dynamic changes in our society, environment, and above all, political changes. These political changes, they lead us to policy implementation failures of the health system, especially in our health system delivery and health insurance systems. But as I always tell people, life can only be understood by looking backward, but it must be lived looking forward. If you look at the situation in Africa, look at the demographics. It's a very young population, which means that we will definitely have a lot of neurotrauma cases. But again, we have about only 600 neurosurgeons. And if you move to West Africa, where actually I'm from, we have about 110 neurosurgeons, and the majority are in Nigeria. That has about 100 of them. No, we have about 150. Nigeria has about 100 of that. And then, unfortunately, even if we want to develop neurosurgery, it's impossible if we don't come along with the rest of the specialties like radiology, anesthesia, critical care, because as a neurosurgeon, you do a critical case, what happens next? Nothing. He dies because you don't have good ICU. So a neurosurgeon always finds himself as a king because everybody looks at you to do something, but as a slave because you need to get all these people along and you have to be someone able to convince them. Now, here's the situation in Ghana. As at this morning, we had 28 neurosurgeons. 20 of them, including myself, were in the capital, meaning that it's level 8, right? And then 5 of them are in the second capital, meaning that level 3, distributed for the rest of the country. Now, my neighbors, Togo, Burkina Faso, and Ivory Coast, they have 332. Now, what that means simply is that most of the neuro cases, they die before they get to the hospital to get to neurosurgery service, or simply they become more complicated. And I started with the Star of Life because if coupled with this, your pre-hospital care is not good, then it's a total disaster. Apologies for some of the images I was showed. Since I was coming to India, I brought this because this happened in my country in 2001 when a building collapsed. This is a shopping mall, and I took Melcom Mall simply because it's an Indian-owned, one of the biggest chains in my country. This happened also in a football game where there was a stampede in the stadium, and we lost about 127 young guys. And this is what led to my country establishing a free national ambulance service, which I was part of it and worked with them for 7 years as the deputy director. Now, what we know is that also road traffic accidents, because most of the issues I spoke about, lack of discipline when it comes to political changes, is that most people, they don't follow the rules. So we have a lot of road traffic accidents, unhelmeted motorcycle. And you can see that over the years, the trend is that it just increases. Now, this is what happens regularly. And now I'll move to where I work, which is the Greater Accra Regional Hospital. It's just one of the places I do neurosurgical interventions. It's a public hospital. And I can confidently say that it's the most well-equipped hospital within the West Africa sub-region and one of the best in Africa, simply for a reason which I'll come to. Well, it's the only hospital within the sub-region where you find an O-arm, you find a microscope, you get endoscopy, you get vascular things, you get stealth, you get, we do transoperative ultrasound and use ultrasound to follow our patients. And then thanks to Dr. Gupta, I wish he was here, but well, we had the craniopagus surgery in Ghana, and he was very fundamental in helping us, and we even acquired 3D printing. We do that in Ghana to be able to. So this is the basic setup in our facility with everything with CUSA, and even an ECMO machine, which we've never had to deploy it. So here is the rich hospital experience. I just took just 2 years, and it's a referral hospital. We have like 658 cases of TBI, close one 561, open one 97. And if you look at the pattern, these gentlemen and ladies were all between the age of 20 to 29. That's a disaster for our economy. Because, and if you do have one disabled person in your family, you understand what I say, because it changes all the dynamics of day-to-day in their family. Now, if you look again, most of these people, it's all about road traffic accidents, which means we need to do better laws and enforce them. We have the laws, we just enforcement. And then about 18% of the people usually die. And, well, Ghana is a very peaceful country, and we don't see a lot of gunshots. Most of our issues are rather with motor RTAs. Stab wounds have also become frequent, and these are some of the cases we see, nails and cutlasses, and I'll just keep skipping on this so that I'll get to this. When you talk about neurotrauma, people want to know whether you do ICP monitoring and all that. Yes, we do, but selective cases. Because I started with a preamble that our national health insurance covers the basic. Once you get into ICU, everything is cash and carry. And cash and carry here means we are not costing for you to pay at the end. It means you put your money in your pocket, bring it, buy the items, and then we do whatever we got to do. If you don't have, I'm sorry, that is how it is. So this becomes so difficult, and one of the things I did ask yesterday, one of the neurosurgeons here was our senior colleague, Honorary Shabra. Is he still alive? I would have loved to see him, because when this chance came to Africa, to Ghana, they solved a lot of problems, because they were so affordable as compared to when we use the Medtronics and those shunts that are programmable. There's thousands of dollars that the people cannot afford. The EVDs, we use them all the time, but for selective cases, and one of the things I personally have found very easy is to use the ultrasound, both for brain tumors, follow up in ICU, check the optic nerve sheet just by the bedside. It helps a lot in least developed country where you don't have a CT scan, MRI all the time. It helps you to take decisions. So this is part of what we do in my facility. So you can see the bedside ultrasound we're doing here. I will move into spinal injuries, a retrospective study just for 18 months. You see that we saw 185 patients. Now get this right, my facility are people who are referred to the place. But because most of the trauma cases, they die on the road, or on the way to the hospital because of a weak transportation system. We see that. Most of them were spinal injury. And again, if you look at the ages, they are usually the productive age of the society. And you have to, couple with that, look at the life expectancy of a country, which ours is around promedio of 64. So if you got all your people between 25 and 30 dying, then that is a serious case we have to have a look at. RTAs take the chunk of the cases, and most of the time they come with spine and brain injuries and other parts. Now, I'll just skip to this so that we see. We are usually able to operate just 47% of what we get. And the reason is that when it goes to implants, and I'll talk about that here, then the patients got to pay for them. And it's very difficult to get money to buy implants and all that. If you look at it again, we are facing a lot of issues that has to do with nursing care, because most of the patients, they develop bed pressure sores and all that. Now, this is very important because we are using this to develop policy. We see that about 56% of the people come in via ambulance service. The rest, private cars, taxis, and that is the worst part you can get, because they just push them into the taxi and cause more damage than if we had a good ambulance system that could be around. And let me say that we are within the West Africa zone, and in Africa, we are the only people with national ambulance service. So if I'm talking and complaining or crying this way, you can imagine my neighbors. Again, my facility has 2 CT scan, 1 MRI, but the majority of the places or regions, we have a region, I don't know what you call it here, but it could be province, a whole entire province with a CT scan. So when you have a trauma, it takes too long time before you get the images. And health insurance covers only the x-rays. The CT scan and MRI, you got to pay for them. But in my facility, yes, we cost them, we do them, and then later on you pay for them. Because of that, we are able to get good numbers of cases to do. I bring this child because she was in school, and that was 16 years ago. And she fell, broke the waist, and she was home for almost 3 months before she could get to see a neurosurgeon. Those days, we didn't have those polyaxial screws that you put. So if you look at what we did, and we had to do this 16 years ago. And when I saw her go home after 3 days, I said, the help of an individual is worth more than all the riches on earth. Now, neurotrauma is a burden in Ghana and in Africa. There is the need for comprehensive development of all specialties, including neurosurgery, anesthesia, radiology, etc. And the health insurance system is the way to go. But now I'm shifting to another point, which has to do with collaboration. Is there room for collaboration? And that is part of the reason why I'm here. Because as I say, I'm a policymaker, besides being the neurosurgeon. And wherever I go, I try to make advocacy for collaboration. My first microscope I got in 2003, way back, was by WFNS with the basic set, that small microscope I applied. And I remember Lady Kato, she was the secretary by then, and they approved. We collaborate with FINS and other private and public places, individuals, and here I put Dr. Gupap, because in Ghana we have a saying now, we usually wait for people to die and then we celebrate them. He was this, he was this. In Ghana we say no, we celebrate you whilst you are alive, so that you know how much we cherish you. So I put there, he's a good gentleman. Now, there is a reason for that. When we had our conjoined twins, most people wanted us to send them abroad. And when I place a call, I just found it on the internet, I place a call, I say, I've seen that you've done a conjoined twin before. Say, yeah. I say, I want to do this. They said, I'll help you. Let's get it done in your country. It will change the game. And that is why today, with that decision we took, we now have the OAM, we have the this, because we push and we got everything that at least could help us develop neurosurgery. Now, the next thing is that in one of his visits, we have this child, and I don't need to explain this x-ray to anyone, fell from school, and we didn't have the screws. We didn't. So he convinced, and I think they are out there, a company, an Indian company, they traveled to Ghana free of charge, brought the screws, they brought everything, and the surgery was done in Ghana. What else can I ask for them to say thank you so very much to the park and then the company? I think they are out there. I'll give you their name. Yes, that's the Cosmos Surgical Private Limited. In fact, use more of their screws. This is the generosity of that company. We also have in Accra, I think, When I was coming and I saw this, when I was preparing this and I saw this, Accra International Medical Science, it looks like All India Institute, well, because it's a private hospital in collaboration with Indians, so in Ghana. So I thought they were trying to export this into Ghana. Sunshine Diagnosis is one of the leading diagnosis centers in Ghana. It's also Indian. And then we have the Esther Group of hospitals. They just had a meeting last August in Ghana to see all this collaboration that can happen. We have Apollo clinics. We used to send patients there. IBS, I've personally spoken to them on their spinal stimulation and all that, but well, we have many Indian companies. But there is one thing that usually strikes me, and is that in Africa, unfortunately, we are not able to do a lot of research. And there are so many reasons for that. Because the first thing is when developed countries come out with protocols and guidelines, they don't favor us. Because what you treat a case, you send it to the journal, they'll tell you that, no, did you do this? Did you do this? Did you do this? We don't have. We only, but the patient survived. That's the most important thing to us, by the way. And then you find out if you, as a doctor, have to put your hand in your pocket and pay for any publication, it's impossible because your salary is scanty. And you find out also that when you have the cases and you want to do the research, you need a grant. So it's just one problem after the next. And I think that there's the need for WFNS to look into this so that, and then we can also increase the collaboration between the SAF, and I think that is one of the way to go, because we have similar cases, we have similar problems, and we can come together and publish easily, and it's one of the places I'll be talking of. I usually say nothing would get done at all if a man waited until he could do something so well that no one can find a fault. So with this, I don't expect that it will be perfect, but we can work together, and we are willing to collaborate with anyone, private, public, or individual, or from any field, from any of you. That is how it started with Gupat, and I think we can all do it. Those of us who are a little old, we remember this picture in 1994 when Costner took this picture. He even won the Pulitzer Prize. This was in Sudan. This kid was struggling to get to one of the UN camps for food. The vulture was waiting for the kid to die so that it would feed on him. He took the picture. 3 months, he won the prize, and 3 months later, he committed suicide of depression. And I always say that you may not have a lot of money in the bank, but if you've ever helped alleviate the pains of others, then for sure, you're a very rich man. I know you also know about this picture, which is the view of the satellite view of the world at night, and you can see that actually all these places are in darkness. But I do believe that if we all collaborate, one day we should be like this. So let's join hands and let's help each other. Thank you so very much.
Thank you very much for this wonderful talk. Yes, sir.
Actually, I think it's wonderful talk. I was in Europe, in London, about 30 years back. Most of the people from Africa used to go to London for study. I used to tell them it's a national hospital, Queen Square. I used to tell them, why do you come here? Why not AIMS Delhi? They don't answer. So what do you think that? Why do people go to Europe? Costly countries for training. A lot of Africans go to Europe for training.
You see, it's a multifactorial thing which starts with the mindset. Because if you look at it, most African countries are very tied to their colonial, what we call masters. And it's been ingrained in the mindset that that is the best place to go to, which is not the truth. And it's also been ingrained in the minds, even today, our ties economically determines where people want to go. Our social life determines where people want to go. What they see on the TV determines where people want to go. Fortunately, today with social media, we see different things around the world. But you sit in before the TV, all you see is, okay, so they show a country where you could get the same service, but they see many poor people. And they show you another country, or in the movies, then you see this big hospital, people are surviving, they are doing organ donation program, they are doing this. And so it's that whole thing, propaganda around it, that influences people's mind. But if we are able to come together and find a different way of changing that mindset, things will happen. And that is why I call for this collaboration.
Thank you so much, sir. I learned much from you. I'm on the board of FINS, and I'm the volunteer coordinator. So I was going to walk out with you and exchange information.
Very good.
As Professor just mentioned, a recent opportunity came when, instead of finding a place in the West, somebody wanted to come to Kansas or something. I said, why not Ames? And so Dr. Sarath Chandra, and I called him up, he agreed to maintain, so be cheaper, better, et cetera.
We make it free.
What?
We make it free.
And when you come to places like this, you can learn something easy. You mentioned in Chabra, Matthew Joseph, a long time ago, taught me, he used a number 6 feeding tube, which is sterile, is stiff enough, and he said, you use that for ventricular drainage, ICP monitoring, and I asked him to publish more than his case report, et cetera, but he hasn't, and he's done a few hundred of those. You don't have to do that. I just want you to know those are techniques and tricks in an urgent or somebody couldn't pay for something. Those are things you can learn from here, from people I'm coming to learn from.
All right, thank you so very much for that.
Any other question? Any other question?
Maybe, Madam Chair, if I can just pass. I see a lot of young people here just like me, and I just want to say that collaboration, you don't need to be rich. We can, this time is just about send an email, I send an email, and we just start talking. Let's publish one paper together, and that is how it starts. So I encourage and welcome everyone. Thank you.